Well, good morning from Miami. Welcome to a special edition of Lipid Insights, where we get a chance to meet with some of the authors of some papers recently reported out and being published by the National Lipid Association. We're at the NLA Scientific Sessions in Miami at the end of May 2025. I'm joined today by my colleagues and friends, Willard and Beth Jackson, and we're here to talk about a paper that was just launching called LDL Cholesterol Management Simplified for Adults. Lower for longer is better, guidance from the National Lipid Association. And so thank you for joining us. My name is Dan Soffer. I'm a past president of the National Lipid Association, and I'm an internist and lipid specialist at the University of Pennsylvania. So I'll start over here. I'd like to hear who you are, why you want to talk to us today about LDL Made Simple, and how you spend your time in clinical and other practice. Eileen, can you start us off?
Thanks very much, Dan. It's a pleasure to be here and to talk about this. Talking about simplifying anything is usually very complicated and takes a great deal of energy in order to do it well. So I hope this is productive. I am an internal medicine physician with clinical lipid specialty. I work for Ascension Healthcare in Wisconsin. My role also includes operational and administrative aspects of healthcare, which has been incredibly instructive for me in terms of how I look at clinical practice in general, and especially in terms of the need for simplification in order to make things actionable. So I am also the incoming president-elect of the National Lipid Association, very honored to be accepting that role. We are talking about LDL today because we recognize that there is an issue. LDL cholesterol is one of the basic fundamental elements of prevention in terms of cardiovascular disease. And somehow we still can't get it quite right.
Great. Thanks for that, Eileen. Beth, who are you?
Thank you very much for having me this morning. This has been a really great project to work on with Eileen, and I am Beth Jackson. I'm a clinical nurse specialist, and I'm in the state of Texas, and so that is the typical role for me is that of a nurse practitioner or physician assistant or associate in other states, but it is state governed. I have been working in preventive cardiology since 1997 and in two different organizations. I'm currently in between jobs. And the LDL management made simplified is important because we really need to promote this better screening practices. That I really want to get that word out. That's what we're very low on, and it kind of echoes one of the NLA missions that we're focused on and getting back on CMS as a quality measure. So by screening, we're going to support timely initiation of appropriate therapies and thereby lowering risk of patients long term.
Great. So this document has helped us get better at finding those who need treatment and getting the best treatment possible so that everyone can do better. So, Eileen, your comment about making something simple is one of the hardest things to do. I totally agree with you. When you think about all of the most complex things in the world, they're generally described by just a couple letters, very short words that mean a lot that we oftentimes can't really pin down. So you can't get much shorter than LDL. What is LDL? So that make sure we're all on the same page here.
All right. Well, I've come up with this description that I provide to my patients and my colleagues often in order to help them understand the role of cholesterol and quote-unquote blood fats. As I usually start out, cholesterol is a fat. Fat does not dissolve in water. Serum is largely water. Therefore, cholesterol esters and triglycerides, which are both different types of blood fats, are carried in particles. I also describe those particles sometimes as vehicles of different sizes. As it happens, the LDL particle, which is about a 70 nanometer particle containing both cholesterol esters and triglycerides, is the quote-unquote right size to initiate damage to the endothelium. And by doing so, it starts a cascade of events that essentially induces inflammation and brings in all kinds of nasty tumor necrosing factors and macrophages and all of these other things that eventually build up what I have also come to identify as little biological volcanoes in our arteries. And I also describe to patients that an artery is an artery. It doesn't matter if it's going to your kidney, your brain, your heart, your legs. Nevertheless, we need to be very aware of the impact of LDL cholesterol because of that specifically. It's not that LDL is the only factor by any means in terms of developing atherogenesis, but it is clearly one of our most important and reflects an excellent biomarker.
Yeah. Thank you, Kayleen. That was really helpful. I just want to make a correction because I think you were, when you threw in some details there, LDL particles are typically more like 20 nanometers, but all of the particles that get into the intima have to be less than 70 nanometers. I think that you were on a roll. I didn't want to interrupt there, just for correctness. One of the pictures we show in the foundations course of the role of these particles in atheroma is an old graphic that I have been using for years in teaching, and they show, part of the graphic shows the disruption of the endothelium and destabilization where the plaque ruptures. And it looks like a volcano, as you say.
Yes.
And I always point out to the students, I say, I don't think it's really a volcano that happens, but it does look like a volcano. But I think I take your point that, it really is volcanic, right? There's smoldering heat, there's inflammation, and then an eruption.
And it definitely gets people's attention.
It does. It
And
does.
that's
number one.
I think that is the point. When we're addressing things with our patients, we have to help them understand, as well as our colleagues. I always say patients and colleagues together. We have to help them understand why something is important.
So Beth, this concept that you have this process going on for years and years that you're not really aware of. You don't feel the heat of that smoldering volcano until the volcano erupts. How do you get that across to patients? And how do you talk to them about making sure that they understand that this thing that they have in their blood is contributing to this process and that one day may cause that eruption?
So I draw out the process for them and show them what atherosclerosis looks like and what the components are, and add inflammation and then, it is the number one cause of a heart attack is when it ruptures. It's not just the constant buildup and accumulation of plaque. And so I hone that in with my discussion with the patients. And then I start going into the treatment and what the treatment efficacy is on those plaques to keep them stabilized, to keep them from growing and initiating and so forth. And that really seems to, when they see the diagram, that really seems to, the visual is helpful, I think.
Yeah.
Yeah.
Yeah. I don't know if you guys know this, but a picture is worth 1,000 words. I can't take credit for that.
Never heard that before.
Yeah, I agree with you. I think drawing pictures for patients, talking about and using pictorial language where you describe a volcano, and there's a lot of focus on the buildup and the blockage, and I usually point out to our patients that the blockage can cause symptoms for sure, but that's not what kills you. It is the eruption, and so expecting to make a decision based upon symptoms is the wrong approach. I don't think I'm telling you anything that you don't use in your regular day. But so,
well, in addition to that, I always tell my patients you can have up to 70% narrowing or obstructive process going on in the arteries and have a normal stress test, and because the perfusion is adequate for the moment.
Yeah. So lipidologists talk about more than just LDL, but for the sake of this conversation, we're talking about LDL. And so is there anything else of concern with LDL, or is it really just LDL is something that contributes to plaque, or do we think about any other disease processes? Is it really just about plaque and the consequences of plaque?
Well, when we talk about plaque anymore and atherogenesis in general, there's the combination of the plaque formation, the activity of that plaque, but also the inflammatory process that's contributing to it. Yeah. And we're not talking about triglycerides today, but triglycerides have a role, especially in terms of maintaining that inflammatory component of the endothelium. But LDL is important because it's a biomarker, and it is a very effective biomarker in terms of monitoring not only incipient disease or disease before it becomes symptomatic, but also in helping us guide our treatment. Right. And I'm not sure if this is the point to introduce the fact that we have not been measuring LDL as consistently over the last 10 or 12 years. We have instead substituted for that the use of statin therapy. And we need to get back to measuring because, as Paul Ridker said, doctors won't treat what they don't measure.
Yeah, very good point. So let's talk about the measurement. We're saying LDL, but we're really talking about measuring LDL cholesterol content. And there's some other metrics that we use that are meant to reflect the same thing. Beth, do you want to talk about that?
Sure, yeah. So as we pointed out already, that LDL cholesterol is a great marker of validated marker for the amount of plasma LDL, and it's a surrogate marker for the burden of circulating atherogenic lipoproteins. But in certain populations, it might not be the best thing to look at. And I think that we're going to have to update this article probably in the not so distant future, especially with the new guidelines underway currently. But in the patient population that have high triglycerides, obesity, cardiometabolic syndrome, metabolic syndrome, diabetes, your paper on ApoB and non-HDL points out that that is a better indicator because they reflect all atherogenic particles. And so the LDL-C might not be the entire story.
Well, I won't take credit for that paper, but I think you're referring to the scientific statement that from the NLA about ApoB and clinical management.
Yeah.
And I know you are. Thank you for bringing that up. So ApoB is another metric of atherogenic lipoproteins. It's a focus on the protein as opposed to the lipid content. And so you're looking at the particles in two different ways. In one case, you're looking at the sort of as a volumetric analysis, right? Like what's inside of all those particles, and the other is you're looking at the numerical assessment of those particles, how many particles there are. And for all intents and purposes, LDL is the prevalent atherogenic lipoprotein, and so if you have a measure of all of the atherogenic lipoproteins, almost all of that is LDL. So we're just looking at different ways to measure LDL. Kathleen, do you ever use any other metrics like LDL particle number, small dense LDL, particle size, anything else like that?
I am an ApoB fan, and I also educate my patients as to why I'm doing ApoB because it's not the most common indicator. But as you've just said, it reflects the number of particles that can cause atherogenic damage. And in addition to that, it essentially reflects what the advanced lipoprotein testing calls a particle number. The reason I do not use particle number or dwell on the small dense LDL particles, although I think there is a clinical role, pathological role, is because we don't have outcome data that is specifically associated with those small dense particles. They may be more atherogenic, but what we need to do is continue with our basic approach.
Yeah, I like that you brought up the basic approach, right? You know, we're lipid specialists. We like to target in and really magnify small nuanced differences between our patients because this is what we think about all day. This is how we spend our time. But really, when you need a metric that we can use for the whole population, LDL cholesterol has been used for generations now. And we have this, all of our clinical trials have used LDL cholesterol as the metric of choice. So we have a wealth of data from LDL cholesterol as opposed to LDL particle number or even ApoB or even non-HDL cholesterol, right? So, and we actually now have some improvement in the way we measure LDL cholesterol. Have either of you thought too much about the novel mathematical formulas we have for this, or are you still relying on Friedenwald formula as your main metric?
Don't use Friedenwald any longer, although my lab at my institution still seems inclined to do that. But I think, as you point out, that we do have some better options that are more accurate now.
So, Kathleen, when you get the report back and it's a Friedenwald calculation, how do you interpret it? Are you doing the mathematical calculations yourself to convert it to a new and improved version, or like using a mobile app, or are you just jumping ahead and using non-HDL cholesterol or something
I'm using
else?
a combination of non-HDL and ApoB.
Yeah.
And as I said, I try to warn my patients ahead of time what my approach is and help them understand that part of it. I think at this point, so much of what we do when we're dealing with patients is intuitive because we do it all the time. No, I don't make a specific calculation, but I do help my patients, especially when they come back with an LDL of -8. I do try to help my patients understand that there's a bit of inaccuracy in there.
So obviously you're talking about since 2015, right? Because we never got LDL cholesterol as -8 before 2015.
No.
What happened in 2015 that changed that whole thing?
This was revolutionary. This was the development and release coming to market of PCSK9 inhibitors, which I also describe as setting up an ecosystem in our livers.
Yeah.
Because instead of with the PCSK9 protein, if it's attached to the LDL receptor, is absorbed into the hepatic cell, and after one use is destroyed. If we inhibit that PCSK9 attachment, we allow that receptor to be recycled. So again, one of my pictorial descriptions that I go through with my patients is we're establishing an ecosystem that's much more efficient.
So you're less a physician, more of an artist, you would say.
I try to think of myself as, well, you know, they say the art of medicine.
That's right. That's right. So Beth, you see these patients, and we're all old enough to have practiced in the pre-PCSK9 era and the post-PCSK9 era. And so with the old Friedenwald formula, you've had some patients who've come in with negative LDL cholesterol measurements. So I think some of our listeners will be interested in sort of how do we sort that out? Like, what does a negative LDL cholesterol mean, and what can we do? Like, how do we interpret that? What is the actual biological meaning of something like that?
When it's, I mean, you can't have negative LDL, right? So
right, great, that's a good place to start.
I mean, you cannot.
It's
not, so I think, you know, when I'm talking to patients and they're seeing these dramatically low numbers and they start talking about fear of complications from that, I do their non-HDL, ApoB, you know, we'll do further testing usually and reassure them that that's not an accurate measurement.
Right.
And put it into the context as well of the triglyceride measurement, which overshadows the calculated LDL.
So we're referring to the Friedenwald formula from the 1960s that used a very simple algebraic equation referring to VLDL based upon a fixed triglyceride to cholesterol ratio, only to find out that indeed the triglyceride to cholesterol ratio from VLDL and remnant particles can vary, it's not just 5 to 1, it can vary from as low as 1.5 to 1 to 9 to 1. So the ratio of triglyceride to cholesterol varies greatly, and the value of the updated LDL cholesterol calculators, for the Martin Hopkins formula and the Samson NIH formula, that now take into account for that, we're no longer getting these negative LDL cholesterol. So we just fixed the algebra is what we did. So we're still getting an LDL calculation, but now we have a much more accurate, much more reliable tool for assessing that. And hopefully you can convince your home health system to make that conversion. I think it's long overdue, and it is really the recommended LDL cholesterol now.
And the system I previously worked with did use the Martin Hopkins, but there is an app for that too.
Yes.
Yes.
So you can calculate it right on your phone when you get the food logs.
Yeah, we don't have an app for the NIH one yet, so I always go to the Martin Hopkins myself.
I think also that it's important to remind our patients again and our colleagues that you can't go too low.
Yeah.
There is no evidence that there is clinical damage or ill effect of a very low cholesterol. Very low LDL cholesterol. And so now, with the advent of PCSK9 inhibitors and some of our other more novel therapies, we are reaching these very low levels, and it's perfectly acceptable. I continue to work with my colleagues as well to remind them of that, because I have had cardiologists change doses simply because the LDL cholesterol, with their patients, simply because the LDL cholesterol was now 25 instead of 55. And so that's the message that we want to deliver, is lower is better for longer.
Do we have any evidence that being at super low levels is not harmful?
We do. And one of the trials that I look at was the Ebbinghaus, which looked at very low LDL levels, where we have demonstrated that in terms of other pathways metabolically that utilize cholesterol, including in the brain and the adrenal glands, we have not seen any evidence that there is damage or adverse effect from the very low LDL levels.
And I'll add to that you know, if you have people with what's called hypo-beta-lipoproteinemia, which is a huge long word for people that have very low LDLs lifelong, and other models that are phenotypes that have lifelong levels of very low LDL, there does not seem to be any adverse consequences of that.
I'm going to add a little nuance to this, and just put out the nuance. So, you know, there is no, the big question comes up about the brain and super low LDL cholesterol levels. And it's worth pointing out that there is no ApoB in the central nervous system, so thus there's no LDL particles in the central nervous system. But one of the largest depots of cholesterol in the body is the brain. So the brain is making its own cholesterol regularly. There's even some transport of cholesterol into the brain, but not via LDL particles. And the therapies that we use to lower LDL cholesterol, including statins, ezetimibe, PCSK9 inhibitors of all types, bempedoic acid, and even bile acid sequestrants, primarily upregulate the clearance of LDL particles. With one exception that's notable, I think, is that with statin drugs, they not only upregulate the LDL receptor density and clearance of the particles, but they inhibit cholesterol synthesis in the liver and elsewhere. So they do have this physiologic potential to inhibit cholesterol synthesis in important body parts like the brain. So one would think that if we have 30 plus cardiovascular outcome trials with statin drugs, that if inhibiting cholesterol synthesis in the brain was really bad, we'd probably see it in some signal of that in those clinical trials. Does it ever give you pause for concern that we're inhibiting cholesterol and we may be inhibiting it in important body parts like the brain?
I think that's an excellent point to bring up, and that is one of the most common fears that I get from patients and other clinicians, and so I do not, and I educate. I mean, you just have to educate them of what you just said, and I think that's an excellent point to bring up.
Yeah.
And we do have to go with the objective data. I mean, that's what we have to function. But I think also it's very important to remind patients that if we're talking about dementia, which of course is the natural consequence of whatever pathology you're discussing in the brain, that what is most important is the development of microvascular disease that is related to the deposition of LDL particles and atherogenesis in the first place. So the evidence does not support that there is an adverse effect on the development of the neural sheath or any of the neural pathways, but we do primarily need to treat atherogenesis.
Yeah, the proof is in the pudding. You do the clinical trials. If there's no real signal of harm in the short-term clinical trials, then you can assume that there's at least no evidence of harm in that time frame. Maybe over a long time frame, there could be. That hasn't borne out. When you look at the genetic data, when you brought up hypo-beta-lipoproteinemia, we don't see evidence of brain dysfunction in those individuals. At the extreme, where there's no ApoB in a rare condition called A-beta-lipoproteinemia, there are medical conditions from not having any ApoB-containing lipoproteins in the circulation due to vitamin deficiencies. Fat-soluble vitamins are carried by these particles too. So I kind of like the concept of leaving some ApoB around. I don't think I'm aiming for zero ApoB, because I do have this concern that maybe there needs to be some for, at the very least, the carriage of fat-soluble vitamins. But we've learned in Ebbinghaus that you can go very low. We've learned from the hypo-beta-lipoproteinemia syndromes that you can go very low and without harm. So I'll tell you what range I tell my patients we're aiming for in that very highest risk group is between 20 and 55 milligrams per deciliter. Is that kind of like what you tell your patients too?
Yes, pretty much. I still remember Gene Braunwald giving a talk at, I believe it was IAS in Toronto a few years ago, saying, and for those of you who may not recognize Jean Braunwald. I do because I'm old and
Kayleen, I remember that talk. I actually remember being at that talk.
Yes.
Yeah.
And he said that he maintains his own LDL cholesterol and has for years between 15 and 25.
Wow.
And he was up there on the podium at 93 years of age delivering a very cogent lecture. So that is part of the pudding that we have proof of.
Yeah, it's great.
Yeah, that's good. Do you do the same thing, Beth? Are you aiming for that kind of goal?
Yeah.
Yeah. Do your patients freak out if they're down around 20 or 25 or so?
They
or?
might before their visit, but not after their visit.
Okay, good. All right, well, while we're on this subject, do you ever pull back therapy because they don't, let's say they're in single digits or in the teens, do you pull back therapy at all?
Sometimes I will if it's a cost issue in terms of altering the cocktail that if we're using ezetimibe, for example, and it is cost burdensome, which who knows why it still is, but nevertheless it is.
Yeah.
And so sometimes from that standpoint, but I don't simply on the numerical basis.
And it's a patient preference too, right? The drug burden, the polypharmacy, wanting to get off several as many medications as they can. I hear that all the time. Or if other clinicians have pulled drug off, then I'll have that conversation with the patient going, and I always, like if they're on 2 or 3 or more cholesterol lowering therapies, I'll instruct them before they leave that in priority wise, if I know that's a goal of them is to get off, we're not going to come off the statin, we'll pull ezetimibe off first or something like that.
And I think it's also really important to look at the drug profile of the patient otherwise, because and the comorbidities of the patient as well, and potentially because of either drug interactions or because of change in, for example, renal function. Altering a dose of a statin may be a very important thing to do. We can't forget that, and we have to continue to function looking at the whole patient rather than just our area.
Agree.
So I think I sent us down this pathway talking about some very specific aspects of LDL and LDL cholesterol management. I just want to get us back a little bit more towards what you wrote in the paper. I know you stressed this concept of monitoring our patients. We're talking about if we go too low, that assumes that you that you put someone on some therapy, and then you did a test for follow-up. Can you just sort of reiterate, Beth, what is our, when we're treating someone, how often should we be testing them? When should we be testing them?
So thank you for that question. That's so important, and that's where we're missing a lot. We don't have guidelines that are very specific to this currently, but when you start and initiate a medication or add on therapy or change a dose, how do you know it's effective or they're adhering to it without checking it, right? So we check at 3 to 12 weeks after any of those situations, and then monitoring at intervals up at minimum at an annual basis when they're on steady state therapy. We did include the children in this article, even though it's an adult-focused article, because there was data published in July of 2024 in JAMA that said 8.9% of the children are being screened as at the time their guidelines recommend it between the ages of 9 to 11. That becomes an adult problem, right, in some patients. And so I think getting the numbers, just adding it to a blood test. We're doing blood tests on people, right? So let's add the lipid panel. It's not expensive. And then screening, the adult screening times is listed currently at every 5 years. I went a little, I think, an asymptomatic, no clinical ASCVD for just monitoring healthy adults. But there's a lot of life that happens in 5-year time frame, right? Yeah. So I think we have to be a little bit logical about that, and I think that's a little bit extended from my viewpoint.
Yeah. So to be clear, yes. That would you say 9% at 9 years old? That you think that's too low a number? We should be testing children more often than just 9% of those children.
So in the pediatric world, right, we have to get these family histories. How old are these parents of of these kids, right? They're in their 20s, and so they probably haven't expressed any complications in the majority, and their grandparents might be in their 40s, again, might not have expressed any, right? So I think screening is super important to catch these.
So why are we doing a lipid profile on a 9-year-old? They don't have heart disease. Why would you check a lipid profile in a 9-year-old?
If you have an LDL over 160 in a 9-year-old, that is hypercholesterolemia. That's when we start to say we may have identified an FH patient, heterozygous FH patient or something like that. So,
primarily we're looking for an inherited monogenic condition that increases risk for atherosclerotic cardiovascular disease and aortic stenosis early in life. So we want to catch them early.
Yeah.
And to your point, they have parents, right? So one of those parents, if they have that condition, also has that disorder.
Then we can cascade screen.
Look at that. Look at that. So we're not killing two birds with one stone. We're doing the opposite.
Right.
So I agree with you. Yeah. I was just being devil's advocate there.
I like it.
So the American Academy of Pediatrics and the American Heart Association in 2011 have recommended that all children be screened between the ages of 9 and 11 as their first screening. And then occasionally even before then, if we know that they have familial hypercholesterolemia.
Premature coronary artery disease or FH in the family,
Yeah, so that's very helpful. And it's a little disheartening to hear that the numbers are that low. Do you think we're doing better with our adults? Are we checking our adults more frequently than 9% of the recommended time?
I think we're doing it more than 9%, but certainly not too much more than 50%.
Yeah.
Especially even in our highest risk population.
Yeah.
We are, there's clear evidence that in patients who have had a coronary event, acute coronary syndrome, ACS, been in the hospital, less than 50% of patients are having a lipid panel done within 12 months of their discharge from the hospital. So the answer is no, we're not doing it well, and we need to do it better.
Why are we doing so poorly at this?
Well, that is the million-dollar question. And I think there are all kinds of variables. We certainly have risk calculators, we have guidelines, we try to impart that information. One of the reasons, of course, that we went to the extent that we did to simplify the understanding of this is because guidelines are long, and primary care physicians, where we really want to focus on primary prevention, cannot incorporate that level of detail into their day-to-day life. And they have a list of 18 other things that need to be done in a 20-minute time slot. And so I think the more we can crystallize the importance of and help our clinicians prioritize the need to prevent cardiovascular disease by using LDL as a biomarker, the better it is.
So are you saying that if we could make LDL simple, that would make this whole process better?
That would seem to be the goal.
All right. Well,
at least one of the goals.
That's fantastic.
Starting with screening.
Yeah.
Check it.
So we have to screen our patients. Once we've identified that our patients need to be treated, we have to monitor their progress over time because, as you point out, things change. Our station in life changes, our habits change, our exposures change to medicines, things change. I think it's worth pointing out that part of the bias of treating without monitoring comes from a fundamentalist, evidence-based approach to care that the guideline committee was really handcuffed into following in the 2013 guidelines. But even in that construct, the 2013 guidelines made it very clear that once you start somebody on therapy, check to see that they're responding. Respond to what the levels are, monitor their progress. In no uncertain terms, they said, make sure you monitor your patients. Somehow that got lost. I don't understand how that got lost.
And it was lost and with no intention of the writing panel.
No.
But nevertheless, the fact that there was no target in there, and if you look at the spectrum of guidelines from 1988 up until 2024, the only one that didn't have a target was 2013.
Yeah.
And I think that distracted people, and it led them to the load and fire strategy. Yeah. Start the statin, which was, by the way, the metric that was being proposed. Well, to which we've been held, and then you're done.
Yeah.
And we're not done.
So we know that if you can get the LDL cholesterol to a particular range, the outcome is different than if you get it to if you don't get it to that low. Yeah.
And obviously, lifestyle management is incredibly important. It's the one of the fundamental portions of the triad of treatment. But we also know that using medications in appropriately risk-stratified patients that in particular upgrade the LDL receptor expression, that we have a significant lowering not only of LDL but of cardiovascular disease.
Okay, Eileen, we're getting on the elevator. We're in the lobby. We're going up to the 10th floor. Tell me everything I need to know before we get to the 10th floor about what you want us to know from this paper.
That LDL needs to be measured and managed, because cardiovascular disease is the #1 killer in this country and globally.
Great, thank you. Beth, we just got to the 10th floor. You got on. I'm going back down to the lobby. Oof. You got 10 floors to tell me. What do I need to know about this paper?
Screening is absolutely important, and the consistency of screening and keeping the LDL managed is going to lower your cardiovascular risk lifelong.
Excellent.
Yeah.
Great. So this was really fun time to have this conversation with you. I do feel like I could talk about LDL all day. Does that make me a little weird?
No.
Okay,
I'm
good.
I'm in the same boat.
Not in the company that you're keeping right now.
All right, well, maybe we're all a little weird. But thank you so much for taking this time. Thank you for the delivery of this fantastic paper. I think the NLA community and beyond will really learn a lot from this. And I think this is a really important deliverable to the entire cardiovascular community. So thank you for your efforts, Beth, Eileen.
Thank you for
keep up the good
having
work.
this chat with us.
Thank you.
Yeah, it's been a great